Hello, this is Jaundice tutorial presented by the SchrDbb with reference a practical guide to history taking and clinical examination by Anwar Qais Saadoon. So we are going to visualize jaundice. So jaundice is a yellowish discoloration of the skin, the sclera, the mucous membrane, resulting from elevated level of serum bilirubin, which is a byproduct of heme protein breakdown. So it can be either due to unconjugated bilirubin or it can be due to high level of conjugated bilirubin. So those are the two main cases. So we have direct bilirubin is the same as the free bilirubin is the same as the unconjugated bilirubin, and the conjugated bilirubin is the unfree bilirubin. And now you also need to know that the indirect bilirubin is the same as the unconjugated bilirubin, and the direct bilirubin is the same as conjugated bilirubin. So those are the points you have to put in your mind. So you have to know that conjugated hyperbilirubinemia is secondary to a cholestatic disorder. So when you have obstruction to the post-hepatic system, that's when you have excess hyperbilirubinemia. It's always pathologic. When you have conjugated hyperbilirubinemia, it's always pathologic. Or from unconjugated bilirubinemia, when you have unconjugated hyperbilirubinemia, it can be due to a pre-hepatic cause, which is excess hemolysis, or a hepatic cause, which is due to a problem with conjugation. And syndromes where you have a problem with conjugation, we have the Crigler-Najjar syndrome. You have the Crigler-Najjar syndrome. Syndromes where you have a problem with excretion. So problems with conjugation, you have the Crigler-Najjar syndrome, and you have the Gilbert syndrome, which are involved with that. And then problems which are involved with the excretion, we still have the Crigler-Najjar syndrome, and we have the Johnson syndrome, if I'm not mistaken. So the next one now, we have overproduction of bilirubin, we have impaired conjugation, impaired uptake of bilirubin, the hepatocytes and all that. So that's a problem all involved. So we have the jaundice issue, you have identification, chief complaint, that's hairish discoloration of the skin, the white of the eye, discoloration and all that. So you have a history of present complaint, you have time of onset of that jaundice, you have distribution and the progression, you have what are the prodromal symptoms, that are shaded features as fever, abdominal pain, anorexia, hematemesis, melena, diarrhea, constipation and all that. You have the color of the stools, the urine, is the stools, the urine dark urine, and is there pale stools. When you have this type of thing, you think of a cholestasis. So now birth history, we have cause of the pregnancy, maternal infection, we have gestational diabetes, intrauterine, low birth weight. You have to know all this. Jaundice during the first 24 hours. So we have history of neonatal jaundice. You need to know that what if you have jaundice during the first 24 hours, it's always a pathologic jaundice. But if you have jaundice after 2 days of life, it is not always pathologic. It may be pathologic or a physiologic jaundice, and we have reasons why we have physiologic jaundice that I'm going to explain later. So we are going to have past medical and surgical history and all that. We have medications such as acetaminophen, example in paracetamol use. We have antibiotics, we have isoniazid, phenytoin, all that can result to jaundice. Family history of jaundice, you have consanguinity, can make you think of jaundice. Family history of unexplained liver disease suggests like Wilson's disease or hereditary hemochromatosis, other genetic causes. You have autoimmune diseases like type 1 diabetes, celiac disease, hypothyroidism can result to jaundice. Hemolytic disorders, familial jaundice, history of perinatal deaths, metabolic disorders is involved. Lung disease, alpha antitrypsin disease deficiency, other member of the family affected, siblings and all that. Social history, you have that involved. Now the key point in jaundice is that the rapid progression and early occurrence in the first 24 hours of jaundice is always pathologic. so that occur persists beyond 2 weeks is always suggest pathologic etiologies. Jaundice in children with past history of family history of blood disorder such as hemolysis, so like sickle cell disease, like with a hemoglobinopathy. So in neonatal period, cephalopoidal progression of jaundice is usually corrected with elevated level of serum. It's usually correlated with elevated level of serum bilirubin. So when you have a cephalopoidal progression of jaundice, it's usually correlated with the elevated level of serum bilirubin. That is a Kramer progression. And then the Kramer progression says that if you have jaundice in the face, if you have only yellowish discoloration of the face, it's going to be 5 mg per deciliter of bilirubin. If you have discoloration of the trunk, it's going to be 5 to 15 millimeters of milligram per deciliter. If you have, it's 10 to 15 milligram per deciliter. If you have that on the limbs, then it's going to be 18 to 21 milligram per deciliter. That's the Kramer progression of the jaundice. So jaundice in healthy neonates on 2nd and 3rd day of life is physiologic jaundice. If you have a healthy child, physiologic jaundice, particularly when there is no pale stools, no dark urine. So we have lethargy, hypotonia, irritability. You can think of Kernick tables, which is a complication of jaundice. When the bilirubin has gone and accumulated in the basal ganglia and results to hypotonia, lethargy, irritability, poor feeding. That's Kernick tables. Jaundice that occur in conjunction with symptoms of chronic illness, e.g. weight loss or pruritus, should raise possibility of an inflammation or metabolic process. The occurrence of jaundice, hematemesis, melena, change in mental status, serotonin in child should lead to consideration of progressive or fulminant hepatic failure. So if you have jaundice, hematemesis, melena, change in mental status, sensorium, that is in the case of a hepatic encephalopathy, you have to think of a fulminant hepatic failure. So from here we are finished with jaundice, and I'll say thanks for your kind attention.